from the exam point of view, if you can remember to answer in your thing. The concept of fluid responsiveness came from this particular graph, the Stallings graph, where you give a fluid challenge by increasing the preload. You can see whether the stroke volume increases or not. So in a normal functioning heart, what happens if you give a fluid challenge from A to B, there is a preload reserve and we can see the stroke volume increase from A prime to B prime. Whereas in a heart which is not responding properly, if you give a fluid challenge, the increase in stroke volume is very, very small. So which is considered as no preload reserve. So for a normal response, the heart should have a adequate preload reserve so that it can increase the output of stroke volume when you give a fluid challenge, and that is called the fluid responsiveness. So static markers of cardiac preload, which measured CVP or volume as a marker, cannot predict fluid responsiveness. That is the current concept. So you have to go for dynamic processes by monitoring respiratory variations in stroke volume, of which first thing is the pulse pressure variation, which is a surrogate of stroke volume, as you rightly said. And other measures are the aortic blood flow measurement by esophageal Doppler, subaortic peak velocity measurement by echocardiography, stroke volume estimated from pulse contour analysis. These are also considered as the current techniques of measuring the stroke volume indirectly by using this variation. And non-invasive arterial pressure estimated by volume clamp method or the amplitude of plethysmographic variation form. In early days itself, when you have a arterial line or when you use a plethysmographic oximeter, the arterial waveform that goes up, the upstroke indicates the systolic contraction. In the downstroke and the gap between the downstroke and upstroke is considered as the stroke volume, and that is considered as what is called the poor man's Van-Gogh catheter. So even if you are not putting in a PA catheter, you can roughly measure the stroke volume by looking at the pulse plethysmographic arterial waveform that is happening. And the respiratory diameter variations of IVC, which is measured by using the transthoracic echocardiograph, or the superior vena cava using the transesophageal echocardiography, can also be used as assess the fluid responsiveness. Now, what are the limitations of these respiratory variations in stroke volume? Because, as I said, the first and foremost thing is we are interfering with the normal physiology of negative pressure alternating with positive pressure. Here it becomes positive pressure all the time. So there is a limitation for assessing the stroke volume fluid responsiveness during stroke by assessing the stroke volume according to the respiratory variation. The first and foremost is patients who are being ventilated, unless they are totally paralyzed or they are totally apneic, they always have some spontaneous breathing activity that will interfere with the mechanical ventilation, number one. The second limitation is using the respiratory variation in stroke volume. If there is a cardiac arrhythmia, this will not reflect the correct response. So variations in stroke volume more related to irregularity of diastole than heart-lung interactions, which is the major basic point on which we assess this particular response. The third limitation is the intravascular pressure induced by mechanical ventilation, even though they are of small amplitude, that may also cause the interference. The fourth is the high frequency ventilation. If it is used, that is also not going to reflect the correct method of stroke volume fluid responsiveness. And the fifth limitation is the presence of increased intra-abdominal pressure. So if the abdominal pressure is increased, that will not allow the vasculature to hold the fluid and reflect the correct response. So these are the 5 limitations for the assessment of fluid responsible using the stroke volume. So there is an algorithm which you can use. What is the purpose of this testing is to see whether the patient will benefit by giving additional fluid or not. So instead of overloading and causing a pulmonary edema or underloading and causing an underperfusion, we want to optimize the fluid given to the patient to achieve the ideal stroke volume and ultimately tissue oxygenation. So ventilated patients with, if they are in acute circulatory failure, that means there is the initial phase of hypovolemia or septic shock would be there. If that is positive, do not test fluid responsiveness. This is the first basic negative thing that we have to understand. So if the ventilated patient on ventilator, if he has an acute circulatory failure and he has features of septic shock or hypovolemia, there is no point in doing the fluid responsiveness test. So in cases where you have a doubt that the patient is ventilated but not in acute circulatory failure and his blood pressure is slightly low or hemodynamic stability is not normal, then the patient with fluid overload in the late phase of shock management, that you first rule out. If that is not there, that means you continue with that. If there is a fluid overload challenge, then test fluid responsiveness glide for removal, not for supplementation. And similarly, initial phase of hypovolemic shock is not there. That is the ideal patient for testing for the fluid responsiveness. So I think little bit of confusion will be there. So first thing we have to make sure, as I said earlier, only when the heart and lungs are performing normally, fluid responsive test will be useful. If the patient has got features of acute circulatory failure and if he has got features of shock, then don't perform the fluid responsive test. Only when the patient has got a normal functioning heart and he is being mechanically ventilated, that is the patient who is ideal candidate for testing the fluid responsiveness. If he has got a hemodynamic instability like low BP and tachycardia, which is a sign of compensation naturally occurring in the patient. Then you go for this sort of tests, which are dynamic tests, not the static tests. So the dynamic tests that you can use are pulse pressure variation, stroke volume variation, tidal volume challenge. That is, you can alter the tidal volume in the respirator or the ventilator. Respiratory variations of IVC, SVC diameter, respiratory variation of IJV diameter, end expiratory occlusion test, end expiratory and end inspiratory occlusion test, passive leg raising test, and mini fluid challenge test. So these are all the tests which are considered as the ideal correct test for assessing the fluid challenge responsiveness or responsiveness to fluid replacement. So depending upon the limitations for each test, you have to do that. And if the patient is going to respond positively, then assess the benefit risk ratio for continuing fluid administration. If the benefit is more, continue fluid administration. If the benefit is going to be less, consider other therapies like vasopressors and other supportive measures rather than trying to depend only on fluid. So the basic point that you have to understand in this particular topic is, first of all, the heart and lungs should have a normal interaction. Second thing is, if the patient looks like to be in hypovolemic state, by giving fluid challenge, whether he will benefit or not without going in for overloading, is the idea of this test. So that can be achieved by doing all these various tests, and then depending on that you can give the fluid support and do the testing. So this is the algorithmic approach to use of fluid responsiveness concept at the bedside, where you can use this. And if the patient is in acute circulatory failure, this is a quick method of doing it the decision making for process of fluid administration is acute circulatory failure, evident of fluid loss, or early phase of sepsis. The same thing what has been given here. If there is evidence is present, then first try fluid administration. If there is no, and the patient is breathing spontaneously, no cardiac arrhythmias, low tidal volume or low lung compliance, then go to the next step. If it is present, go for passive leg raising test, index respiratory occlusion test, or mini fluid challenge. Otherwise, if there is no indication of spontaneous breathing arrhythmias, then use these other tests like pulse pressure variation, passive leg raising, end expiration occlusion, and many fluid challenge. So this is how these tests are used to assess the process of fluid administration in these patients. So you don't have to write in detail about the static lung function test because they are not considered as ideal for assessing the responsiveness. So you have to deal more in detail with these 1, 2, 3, 4, 5, 6, 7, 8, 8 dynamic tests which are considered as the test for assessing the fluid responsiveness. And ultimate aim of this topic is whether the patient will respond by giving more fluids or not to avoid overhydration and pulmonary edema, and at the same time restricting the fluid and producing underhydration or dehydration. Okay, that is all the things that you have to remember with this particular topic. This is a little bit confusing topic, but in critical care setting, this is a very important topic because many times we land up with either fluid overloading in the form of pulmonary edema or generalized edema of the patient by not giving the right amount of fluid, or many times we underload the patient resulting in inadequate urine output, and then we rest fluids and give gastrics and try to do all these things. So the topic is mainly because we want to maintain a normal stroke volume and a good perfusion to the tissues so that ultimately oxygenation of all the tissues are taken care of without neither overloading or underloading. That is the main idea of this talk. If you understand that point, I think this will be easy to uh, understand. You can revise that again and again by reading these points. Okay.